Hi everyone, I'm Dr. Yang from Joint Shantou International Eye Center. Today our topic is open-angle glaucoma. First, we need to know the concept of open-angle glaucoma. Glaucoma is a group of eye conditions that damage the optic nerve. This damage is often caused by an abnormally high IOP, intraocular pressure. Open-angle glaucoma usually develops in people over 50 and is the most common type of glaucoma around the world. Open-angle glaucoma is also known as the silent thief of sight. The learning objective is to understand why open-angle glaucoma is also called the silent thief of sight. In order to understand the mechanism of open-angle glaucoma, we first need to know the normal aqueous humor circulation pathway. In the normal eye, aqueous humor is continuously produced and drained. The picture shows us how aqueous humor normally circulates. From the red arrows in the picture, we can see that aqueous humor is initially produced by the ciliary body and passes through the pupil anterior chamber and to the trabecular meshwork, then to the sclerovenous sinus, and finally back to the blood circulation. The dynamic balance of aqueous humor production and drainage ensures normal IOP. High IOP is caused by an imbalance in the production and drainage of aqueous humor. We know that in acute-angle closure glaucoma, the anterior chamber is shallow, the angle is closed and blocked by the pupil, preventing the aqueous humor from draining out by the trabecular meshwork. So, the aqueous humor can't even reach the drainage system. However, in open-angle glaucoma, the anterior chamber is deep, the angle is wide. The pupil doesn't cause any blockage, then wide IOP will still increase. Although the anterior chamber angle is wide open, the endothelial cells in trabecular meshwork and Slim's canal are impaired. Consequently, only part of the fluid can be drained, the rest has to flow back and gradually accumulates within the eye, which eventually leads to increased IOP and damage the optic nerve. Unlike acute-angle closure glaucoma's rapid increase in IOP in a short period of time, this process is slow and quiet. You can barely notice it. Patients with open-angle glaucoma usually have no symptoms at the early stage. Occasionally may have a feeling of soreness. This picture shows us that with disease progression, the visual acuity gradually decreases and the visual field becomes narrow. In the late stage, the patient only has tunnel vision. That's why open-angle glaucoma is also called the silent thief of sight. It comes on so slowly and painlessly that you can barely feel it. And by the time you do, it's likely that the high IOP has already done a lot of damage to the optic nerve. Here we have the size of open-angle glaucoma. The anterior segment of open-angle glaucoma looks just like a normal eye, with wide open angle and deep anterior chamber. The most important site is the change in the optic nerve. In the normal eye, the optic nerve head is pink. The cup-to-disc ratio is around 0.3. The disc rim is intact. However, in glaucoma, the optic nerve head looks pale, the cup-to-disc ratio increases, and the disc rim has defects. Sometimes there is even disc rim bleeding. All of these signs suggest that the optic nerve has been damaged. Now, let's discuss the investigations for a patient with open-angle glaucoma. Since the anterior angle is open, we only need to use gonioscopy to confirm and examine the morphology of the trabecular meshwork. UBM and anterior segment OCT are usually not needed. Visual field examination is used to measure the function of the optic nerve. The report is very intuitive, and the black spots indicate that the optic nerve function is impaired. OCT is an objective examination to assess the damage of optic nerve fiber layers. The green color indicates normal, while the red color tells us that there is damage. Because open-angle glaucoma is asymptomatic early on, when diagnosed, the optic nerve usually has been seriously damaged. So, how can we catch it earlier? To answer this question, we first need to know the risk factors of glaucoma. The risk factors include older age, usually over 50, high myopia, previously eye trauma because there may be mechanical damage to the anterior chamber angle, thin central cornea, since it's less resistant to high IOP, long-term steroid use. It will affect the drainage function of trabecular meshwork. Race. Data shows there is high prevalence in African Americans. The best way to catch open-angle glaucoma early is to have an annual eye check, especially for those with risk factors. This table shows the main differentiating features of open-angle glaucoma: angle closure glaucoma, normal tension glaucoma, and physiological large cup-to-disc ratio. The anterior chamber angle is shallow or even closed in angle closure glaucoma, while it's wide open in open-angle glaucoma. Open-angle glaucoma involves gradually and painlessly, while there would be a sudden onset and severe pain in acute angle closure glaucoma attack. The disease progression of normal tension glaucoma is also slow and painless. However, the IOP is normal. The cup-to-disc ratio is increased in both open-angle glaucoma and physiological large cup-to-disc ratio, but the visual examination reveals optic nerve damage in the former and is normal in the latter. Let's finish off with the treatment for open-angle glaucoma. The main treatment goal is to reduce IOP so as to protect the optic nerve. We can use topical beta blocker, prostaglandin analog, alpha agonist, and carbonic anhydrase inhibitors. If medication fails, laser therapy or surgery should be considered. Regular follow-up is necessary. These are my references. Thank you for your attention.